Good evening, ladies and gentlemen. For the people who are on this side, India and around, and good morning for the people who are on the western side of the world. This is our webinar, which we do every quarterly for 1 hour at the same time, and we declare the topic. The recordings, we also put it on the YouTube so that if somebody has missed it, they can listen to it. We have the knowledge platform where we have our own magazine, we have the conference, we do the webinars, which are complimentary, we have club meeting, which is also not for profit. All these are just to tell what are the healthcare innovation and how technology and innovation together can bring down the healthcare delivery cost. That is for the public to see that how that can be systematized.
Voice is not there.
Today is a very good day for me because one of my very renowned and friend who is a double PhD, who is been professor in a couple of universities, you must have heard the flyer which we have sent to you, that all of you, more than 100 people have registered, and all those people must have read what it is. This is the study which was done, how technology, and not today, many years back. And I was surprised when I heard it in abroad in one of the conference that such case study was lauded by the people from abroad, and then how we can duplicate it in our own place. Of course, Professor Armungam may tell you all about it. His presentation will be for 30 to 35 minutes. And after that, you keep sending your questions. We will record these questions and we'll request him to answer. And ultimately, I'll sum it up and conclude. And that would be the format for today. So you people, please keep your questions ready and keep sending. Why we have kept half an hour to 35 minutes presentation so that you have more time for question and answer. The Professor Mungam, I can only see him that he's already there. Good evening, Professor, and nice and welcome you for this webinar. And I'm sure many who are on other side will be benefited, and some of them will even write to us what is to be done and how it has to be done. We have record of every people who were attending it, their email, etc., and we will be in touch with them whenever they need your or our assistance. I hand over to Professor Mungam. Thank you very much for your valuable time. I know he's a busy person, but being a good friend, he never refuses me. So I'm grateful to you, sir, that you are on the side, and I hand over them to you. Thank you.
Thank you, sir. Thank you. Well, you can all see this little presentation. I have got it on the screen. Gentlemen, you're all able to see the presentation. I'm trying to show it on the screen. Hello? Today's discussion, I'm trying to take on a topic called digital health innovation, which happened in Tamil Nadu, which is a very successful model. All over the world talks about it. And coming to this, I have a brief history to speak. As you all know, Tamil Nadu is one of those states which has been doing wonderfully well in health over the past 3 decades, because we have created a lot of systems, interventions in the government, the public health systems. So the public health system, you all know, which is largely catering to the poor people and the people who depends on service delivery from the government. So the government hospitals deals with this public health system. Well, coming to this digital health, you all must know, Tamil Nadu is one of the states which is the southern tip of India, which is actually a fairly large state, and which has got a population close to about 72 million people, 7.2 crores in Indian standards. Actually, the land has a history of about 6,000 years, and you all may appreciate that this is one of those urbanized state in the country, and has got an area close to about 130 lakhs square kilometers, and it's 11th largest Indian state. Of course, you have huge GDP. In fact, Tamil Nadu is considered one of the best in terms of the GDP and economic growth over the period. And of course, health innovation also we have been. It has happened a lot in Tamil Nadu. 1 minute, I think it's not moving. Well, I think this is about the structure. This is the structure of Tamil Nadu health scenario. Actually, Tamil Nadu health system is under the minister, and you have got Health and Family Welfare Department, which is actually controlled by the Secretary to Government, and you have got administrative wings, which includes a directorate, and of course we have a society as well, and an administration system. This administration system which controls the entire health delivery system of the state, and this reports to the minister, and the minister will be the executive, and he will be making necessary policy change with the approval of the state legislation. And this is this is the way every state functions, and Tamil Nadu also no difference in it. But looking at this digital health system, first of all, we have created certain goals to provide accessible and affordable healthcare based on people need, then to deliver good quality health services, which is actually lacking. If you look at the various scenarios in the country, you have got better expenditure on health, but the delivery to the patients, particularly the poor one, is very, very bad. That's what we have been watching around the country, and Tamil Nadu as an exception, because we have created a system called TNMSC, and we have streamlined the process of distribution of medicines and various health deliveries. So that is essentially helped in a large way for creating availability of medicine to the people. Basically, you all must be aware, when a patient is on government clinical treatment, when the medicines are not given on time, what really happens is the disease burden increases, which is a burden to the state. Apart from that, there is a lot of patients who are not given adequate medicine. That's another major problem. What happened? They start developing drug resistance. Drug resistance is a major phenomenon which has affected a lot of people. So we created certain goals which will help the delivery care as well as availability of various health commodities to the patient. So we build various goals which includes the delivery of high quality of health services and to improve long-term health status of the population. This is very important. See, health is a sustainable model. You can't give health for a brief period. It has to continue, because the intervention on health of a person should be continuous. For example, there are diseases like tuberculosis and everything, which needs a long-term therapy and should have a regular follow-up. The relapse of certain diseases also cause enormous concerns. So to improve the management of health and services, we have established accountability among the health workers. Namely, many of them are very casual and they escape out of various reasons. So we didn't allow. We have just brought this accountability into our goal. So then after that, we have created certain strategic directions to the entire administrative as well as the professionals to adhere. One is we have created a user-friendly healthcare system, a comprehensive user-friendly healthcare system. This is the digital intervention, which is what I'm going to speak about. Then strengthen the primary health. You see, primary health is the focus. What happens is many of the people in the rural needs a very constant and workable and worthy primary care. The primary care, once you are not really putting effort on the primary care, disease burden goes, and which will you will be having huge amount of patients walking into the tertiary. Tertiary care is largely meant for only specialized care. So when primary care is not functioning all right, tertiary care will have more load and chaotic. The system becomes chaotic. For example, when we were trying to implement various health systems, I came to understand that many of the PHCs were not functioning at all. But in the roles, they were on the job, but they were not functioning. So we were able to cull out such cases and we could arrest it because of the close monitoring of use of drugs. So that one particular factor has thrown up so much of important innovations in terms of how service delivery happens at the rural level. Then build partnerships for health. We built partnerships and we have ensured smooth and efficient and equitable fund flow and assess cost effectiveness of health programs and build a sustainable health workers. See, workforce is, what happens is we have given a proper training and we have ensured that any person who is trained in health must have adequate experience, adequate years of service, so that they are sustainable and they help the systems to go through. So now if you look at the various institutions in Tamil Nadu government system itself has got SHCs are about 8,706 and PHCs are about 1,421, and of course we were able to provide about 7,191 beds for the people, and we have got sub-district hospital, which is the most important thing at the taluk level, which is about 235 in about 30 districts of Tamil Nadu, which is giving an outflow of about 12,285 beds to take care of the inpatients. And when you look at the district hospitals, it's about 8,478 is the bed strength, and we were able to manage in about 29 district hospitals. Of course, one small district has been merged with another district so that they have a common pool of district hospital. So you have Ayush, you have got urban health, you have got municipal dispensaries, and this is the way it's spread out in the entire state. Now, looking at why would we go through this intervention? This would be a bigger question to answer, because there is a huge rise in cost of delivery because of lack of digital systems, and we have a low commitment of the staff because staff training was not in place. And you have a risk of increasing birth rate. Yes, what happens is birth rate is one thing which we have to control. Otherwise, India is already a populous country. We can't afford to have a huge static rise. There should be an intervention. There should be a proper control on that. Then infant mortality. This is what the whole world look at. Every country's, every country's health indices is looked at by two factors. One is static, that's infant mortality rate, and maternal mortality rate. And these things were static. We were ensured in about 5 years we could bring to a static condition. Now it is improved. And resurgence of bygone disease, bygone disease, like, the people have said we have eliminated tuberculosis completely. Now it's emerging again. So why would it emerge again? So there is an absolute poor care and there is no intervention. It gets increasing. Then weaker referral chain management. That's another point. The referral system, from the primary to the tertiary, the referral care system should be in place. It should have proper digital background. Otherwise, this doesn't move at all. And the lack of integrated health management, monitoring and feedback, which is actually the most important point to be discussed. So when I look at the need for integrated health system management, we always focus on team planning to achieve objectives. So the objectives, who is going to do, how are they going to do? There is a coordination of stuff. What they are going to do, several health programs of the state, and you have got national programs, and you have got district health administration, you have got cut across various levels. You must have a proper planning, and we have streamlined the MIS. See, what happens is, you must all be aware, much of the MIS has been duplicated. So we have avoided redundancy and duplicate, and we have created a unique system where all of them can bridge in, come in, and they can give their things and so on. And then there is an integrated training to improve overall quality of services, and clinics, camps which are serving multiple clientele needs in one single visit, thereby reducing the clientele time, which is the most important point. After all these camps that we are conducting, if everyone has to move from a very long distance to have that their health checked. So if you don't properly plan, and if you don't give all in under one camp, or you please announce in advance what kind of camp you are going to conduct, so that people will not come for other elements to care. So that part we are very clear, and we have brought into our system, so any camp is properly communicated. Then why there is a need for integrated system, HMIS? If you look at the integrated HMIS, you have got first referral unit. What is first referral unit? Is the obstetrician and neonatal care. So these things will have all the PHEs. If you look at the left side, you see all the PHEs, HSCs, families, self-referral, all of them will refer their cases to the obstetricians and gynecologist stuff and the neonatal care at the first referral unit. And on the other side, if you look at the right side, you have got these referral cases. If they have other issues, or if there is a serious problem, they find out of this particular care, they are being referred to the teaching hospital and district hospital and the PHCs and so on, PNH, and all these will be supporting. It is a district hospital can refer back their patients here, and these people also can refer back to them for higher medical treatment. So this particular thing, integration, was neatly in place. So now if you look at the teaching district and taluk, PHCs and everything, all were integrated into a single transit system. So that system connects to the home. So we have built communication among service units and accountability, which was not present before. Absolutely, there is no accountability and no communication among service units, and they were all in silos, and they were not talking to each other at all. So to avoid all that, the system failure, we have connected these within that. So that is the integration we are talking about in the HMIS. Then increase the flow and exchange of ideas. See, there is a lot of brilliant ideas which are being exchanged. So how we can really take these ideas to flow from one to another, and increase the frequency of contact among staff to identify, solve problems which can improve quality, service, more cost effective, and attract, retain users, and facilitate development of internal organization and the wide communication, which is also very, very important. Then establish mechanism for technical consultation among staff. See, technical consultation is the most important thing. One of those I would like to explain to you is, we have created a lot of telemedical systems, and we have created a link between the radiologist and the accident victims. The moment if any accident is reported in any corner of the district, they will be able to take a scan and send it back to them, and they can get that referral, and it goes through. And I just want to give you a little idea about implementation of health management information system, because this implementation is largely depends on the various mechanisms and procedures for generating, analyzing data. So the information, see, actually the moment an information is available, and if you start crunching the information through one digital platform, what happens is it throws out so much of such information. That information will be actually drive your planning and your health planners and your programming, your budgeting, and host of activities. We crunch this data, we know what is input. See, if you look at any government per se, if you ask them any data, what they just do it, they just add 10% of what they have last year and they just give you. This is the normal common procedure adopted by government. But when you crunch the data, and if you know what it is how effective we can use it. We felt it so here. And the socio-economic planners and departments outside of the health sector, sectoral information linkages were built, which gave the policy makers the evidence-based policy formulation. So, and if you look at this, the integrated HMIS, which includes the DCA projects, DPH, the Director of Public Health, and Director of Preventive Medicine, and Director of Family Welfare, all these directorates were connected to an integrated health system, which has drug supplies, budget, service, personnel, and infrastructure. All these things are being clubbed to make your thing. And this is a little design, I mean, it's a pretty legacy design which we have brought to you. If you look at it very clearly, you have got a beautiful, you have got a web server, you have got the data server, and you have got these two are linked, and you have got a huge backup which we have created apart from what we have stored in our cloud. This is also has been kept, and we have integrated the systems in the health department of Government of India, because we get all those information right across the moment they have taken a policy call. And we have created systems in all units. If you look at very carefully, we have got systems in all the units. So all the units throws the information back to this integrated HMIS. So each HMIS will have the complete, flow of information from all of them. So we have done a complete integration where flow of information is perfect. So how do we do that information use and users? So if you try to do, Government of Tamil Nadu has got policy formulation, and incremental planning, and resource allocation. The government's job ends with that. Then the state health departments takes care, and then the district, they will take care of the human resource planning, logistics, and health status improvement, resource allocation. What government does? Government is an integrated unit which will take all this purchased data into them, and they will put questions to each one of them as what really happens and how they have to present their indicators accordingly. So that level of corroboration of data which helps them to go into implementing their schemes and their plans so efficiently. So this is the level goes first from the heads of department to the district officers, then to the FRU, first referral unit, then corporation, municipality, hospitals. Then if you look at the block level PHCs and HSCs, UHEs, all those systems are being connected. Now if you look at the referral chain, you have a feedback, and the feedback flows up and down. It goes in both the ways. If you look at feedback is there in every system. See what if you understand any system to function well, you need to constantly update how the system performances are, so that intervention part comes into play. If you look at this HSC has got screening, referral, follow-up based on feedback. And the PHCs has got risk confirmation and referral to FRU. If you look at the feedback, you have got outward referral and PHC inward referral. That comes to FRL. This picture I have already shown you, so you will have a rough understanding of this. Then the teaching hospital, then the emergency care. So the electronic messaging, if you look at it, the manual messaging and electronic messaging. So manual message, we do it because HCs, the doctors are on the move. So they cannot have an automatic system. So they must have a mobile, and they have to intervene, and they start throwing the information back. So the patient information flows right across the electronic system. So we will have a proper understanding of what's going on. And of course, there are huge data. Each of these referral will throw close to about 6,000, 7,000 inpatients in a day. And these data, which is outpatients in a day, and you will have at least 2,000 inpatients or 1,500 inpatients. So all these are happening. While doing this, you have already got an existing patients and their entry, their exit. So all this data, why would we need this data? Only with this data, you will be able to have a disease mapping. You can say how really various communicable diseases are being existing, the bygone disease or whatever you talk about. You must know how this is being polarized and how polarized in a particular district or how it flows through various districts. You will be able to monitor it. So now ineffective record maintenance is very, earlier we have got such a huge problems. All hospital records are maintained manually, and more funds towards manual registers, and manual registers are dumped into huge halls, and whatever health real facilities have been filled with such useless ledgers, and that ledgers where you cannot transcribe those ledgers because it has been written on various speeds and various convenience. So things were flowing up and down, and duplication of record and poor maintenance of equipment. There is an absolute chaos in real-time record, and there is no institutional level. It has been extremely difficult, and at the end of the day we have only chaos left. So now look at the healthcare. You see the nice pictures how things are being organized now. See, after we introduce this health management information system, the people can walk in and they have a proper room to address, and you can compare. Do you see it's a government hospital? It looks so beautiful and it is made so clean, and because of one extra equipment called computers and the IT, which is transformed the whole exercise. So the innovations achieved, what we have achieved is a unique patient identification, UPIN, and unique institution code across government hospital and offices, and unique employee numbers and user numbers, password for access. And we reuse the drug codes. See, what we mean by reuse of drug codes. See, there are drugs which are supplied by Government of India. There are drugs procured by the states. What drug that comes from Government of India will have that same code be established into a new item of entry, because for convenience of talking to that and this, so we made it that way. Then uniform standardization of reporting formats across all institutions. Then TNHSP has proposed to link the PIN and the UID, and the lab test results are being given patient with test report reference value. Final disease diagnostics is, of course, linked to international code ICD-10. We called it ICD-10. So that has been done. And if you know the transformation, the post implementation of HMIS, we are TN roadmap transformed to a complete digital platform. Data acquisition is through the digital acquisition. We called it as State Health Data Resource Center. This is a comprehensive statewide one which connects all the statistics and the state as well. Now, if you look at the objectives, to function as a repository of data for all tertiary and secondary primary healthcare facilities in the state. So, to utilize the data, convert them into an informal information and knowledge to improve the health outcomes. As usual, we do the data repository at all levels of care, and then we make it into a real policy input. Then policy making becomes simple. And health research, health research is one thing in India. We are weak in India, which is now able to improve because of data that is throwing up and down from this engagements. And private sector also, we are sharing data for various drug related developments and information and so on. Facilitate community participation. We have allowed the community to participate. We have got various agencies like Lions Club, and all of them, and some of those large corporates, they want to do some service to these hospitals. We are allowing them to come in and so on. So now if you look at it, the functions integrate data relating to all health programs in state. Then all data management entitles in the state, at the state, district, sub-district levels, we are connecting. Then we have got a HR, finance, inventory, procurement, etc. Is all the functions are integrated. Analytical work which we are doing from the and based on that we give the feedback to the government. And development of training capacity we have improved, and particularly tools for strengthening data quality analysis, performance evaluation at district and institutional level. We have done a complete building of this data requirements. So now if you look at the stakeholders, all those departments, if you look at the left, you can see directorates, and if you look at the right, you can see all those other societies which is attached to the health department. So all the stakeholders are synced. And now you can see the output. We have got a disease incidence monitoring, inputs for disease control, epidemic response. See, actually, if you look at largely, prevention is better than cure. So to do that, we do various response systems that we have built. So if you look at periodic reports, publications, research outputs, which leads to prevention. So decision support, alerts, notification, indicator dashboard, reports and publication, advanced analytics. So all these are put into the heart of our system. Then health system research is actually driven quite good in Tamil Nadu. Then health profiles, state dashboards, district dashboards, facility dashboards, other reports. Then the policy planning. So it gives all kinds of data. So that helps in a long way, and it is also give ad hoc reports, drill across and drill through, making a lot of trends, analytical reporting support, everything we give to the policy planners. And if they want to understand the digital idea into a workable way, we are able to give them and throw them the right kind of things. If you look at the data sources and data outputs, you have got various forms, DPH, DME, all these directorates under HMIS. Then the data systems, we have connected all these external sources, which comes into the integrated frameworks. Then validation tools we have built, so that staging of all these inputs being validated for data errors. Then it goes to the processing engine. Then configuring reference of data management has been done. And finally, you will say data warehouses stored with abundant information. That information is available for anyone to go through. So that way this system functions a lot. And if you look at the data outputs, you have got state health profiles, you have got indicator dashboard, you have got research reports, you have got health alerts. All these things we flow across all levels of health department. Well, now if you look at the data design, you have got data mining, you have got dimensions, which is very important. Then the data mart design. This is the way we have built the data design. Those who wants to have a little more clarity, may please ask a question, I can answer you. And you can have smart architecture. We have built excellent, actually the Tamil Nadu, we have got an organization called LCART, which is a part of government of Tamil Nadu, that helps us in building this TN SWAN, which connects all the hospitals and everything. And they have provided us the data center for the entire application. And we have built everything on open source and simple, user-friendly. And the institutional training was given, so they were able to do it. So the implementation was all the more successful. And it is a very, very if you look at the health intelligence formats, if you look at all, crystal reports, dashboards, web intelligence, analysis, explorer, all the BI platform we have created, and which throws all kinds of business intelligence. So if you look at the indicators, which is far more convincing, you can see infant mortality has reduced and disease incidence is falling. And if you look at the most of the indicators are reducing. What happens is the information is given for the administrators and the health workers, but mainly health consultants. Then the, the state will have a fantastic output. This is my personal view, and it's happened here. And you see various districts have shown a phenomenal improvement. And surveillance, the incidence of malaria, we have got a clear surveillance report, and that reports help us to really go through all kinds of situation whereby this input, this various outputs was the input for preparing for communicable disease among incidents anywhere and everywhere. And these are the various outputs. Child deaths, if you look at child death, it is far more. If you look at infant mortality, it is falling. And if you look at the DME DMHS level also, it is falling. And child death has been a little fluctuating. In 2009 and 10, you will see huge hype, is because there is communicable. This is opened up, and which has caused some issues. Otherwise, that is also under contained. So if you look at the analytics at the direct rate, you see it has shown a phenomenal improvement. Okay, I think well, I think I have completed the presentation, and if you those who have any doubts, may please ask. Professor? Hello?
Can you hear me? Can you hear me, Professor? Professor, can you hear me?
Sir, I finished. Now, any questions, please?
Yeah. The question from Dr. Chaudhary is, what is the adoption level among the physicians, and what are the steps taken for privacy and security of the data?
Wonderful. See, actually, at the moment, doctors are slowly adapting, because we have trained the health workers. So through them, doctors gets their facility. And some doctors were little IT savvy. They are adopting very well. And number two, regarding data security, as you are aware, in India, we are storing it in proper, protected environment. I think nobody can easily take out the data. But at the primary level, somebody can view it. Somebody maybe, if the health worker supports, she may be able to give some health data out. Otherwise, largely, as a system, nobody can break it.
Okay. The second one is that you have done this 2001 onwards. They wanted to know, if we start doing now for some state, how much time you think we will require for doing this, what you have done in Tamil Nadu? And what would be Yeah. And the another question of same gentleman is, what would be the cost which we for this kind of a work?
Well, I think first question, I think it can be done quite fast provided there is a will in the government. The government must give us free hand to do it. If someone is doing it, the government must give the full free hand. And on top of it, at the secretariat level, at the secretary's level, they must take a strong will and they have to put proper terms to all of them to work accordingly and build the data and try to help us out and try to adapt it. So these things with a strong government, with a good administrative officer, I think it can be done faster. But nothing can happen less than 2.5 to 3 years. 2.5 to 3 years is required for a comprehensive.
Okay.
And the
Yeah.
cost is quite variable. Cost is quite variable because states like UP, it's a large state. We will not be able to understand measure how big it is and how it can be done. And we can Pondicherry is a small state. Goa is a small state. So it's all depends on the number of the population and number of referral units and the number of doctors, number of patients, and so many factors comes in.
Okay. There's another question that can the user or a patient can create or customize report as per their requirement?
Of course, yes, they can, because while building itself, see, while building itself, we necessarily go through all the discussion and note down how much of change they want, what they want, and everything. So, based on their various requirements, only the system is being built. See, once the system is built, and if they want an additional report, all they have to do is to say what kind of reports they want. But the data remains same as long as you give the. If you have the meaningful data filled, you can mix and match any kind of reports you want. That may not be a problem.
Okay, there's another one from Dr. Singh. How will you propose this for implementing in the private sector and integrating it with the government data?
Yeah, brilliant question. I think it is required. I mean, when I look at this, many of the private sector is not very strong in data. They have their own data pilferage, or data is not being, put in for a serious scientific application. They don't do an analytical work on the data. That way, we will be able to do it. But once you are a hospital, what way you want to connect with the government? After all, you may connect only for the insurance. Insurance would be a primary. Now that an insurance is announced by the government, I think seriously all of them should bring into a digital platform. So your digital platform to communicate with the government. Government must allow you to have an connectivity. If the government allows, you can always connect. One. Number two, insurance and other agencies to come and involve, with your hospital, and if you prove them with disease incidents and so on, you will be able to validate your expenditure easily with the insurance. So it can be done.
Another question is that the government sector, as you know, is very rigid because of their regulations, etc., and they want them to be enforced. When you are doing this project, did you find any practical problems of implementing it in the government sector because of this?
Of course, yes. Government is very rigid. People won't give data, and they will not work. See, I have got incidents of implementing a large government of India network in Bihar. In fact, the person said to avoid using computer, they just remove the power plug and keep, and they say computer is not working. We will travel all the way and we find only the wire we will fix and come. Next time they will cut the power supply. So see, the point is, that's all depends on how the hierarchy of officers who are involved and how all of them feels that it is important. See, there is a lot of brainstorming to be done and make them understand what they are working is so important to their life as well as the life of the people. And there should be a serious service motto required. So that amount of briefing is required to bring them to our side to build our systems through.
The another question is that when you get the data, is it where you get it timely and it is reliable, or you find that it is not reliable and some data comes, some doesn't come, and how you handle this situation?
Well, this is something, initially you will not get all correct data. Whenever you are implementing a system, initial phase you will have lot of errors in the data. So all you have to do is you will have to go there, monitor and work with them and keep them updated and trying to correct them and get the data properly. So there is a lot of effort should be put in to understand and correct so that it gets cleansed over a period of time. See, cleansing the data, you have got certain practical things. You know how much. See, for treating a fever, you know how much of drug is required. And if somebody claims more wrong entry, then you will be able to easily understand this doesn't match at all. So we have got certain specifics, and we will try to compare the data initially to streamline. After that, it gets automatically all right.
Dr. Uday wants to know there is SNOMATS is another medical coding system, and ICD-10 is mainly for statistical classification.
Hmm.
Do you think India can also use this coding language or SNOMAT?
Sir, this is just an adaptation. We can definitely adapt, but the point is whether our health workers are ready to adapt. That's the main problem. See, ultimately, this is going to be driven by the doctors. If they are ready to take, we can adapt it. It's nothing, no big secret at all. It is simple. No,
Okay. Can anything can be improved in this process? Like what can be more better in this process after you have done? Lots of other technologies are also available.
Yes. If you look at that way, the world is emerging with technology. See, why I am myself is a professor of robotics. I am seeing a RoboCare in the United Kingdom. NHS has introduced RoboCare. NHS has introduced all those care homes. Lot of robotic application. We love to adapt, but it's not going to happen because we have adequate human being. They are able to work and they are able to deliver. So all we need is first, when we have to have the first level of compliances, then go to the second level, third level and fourth level. So improvements will be completely regularly coming, but those improvements you can adapt only when you have a base system. If you don't have the base system, you cannot adapt any amount of implementation, which is impossible. So the base system has to be done. So that is what I mean, and then from that we can definitely go further.
Okay. Professor Venkat want to know, according to government of Tamil Nadu, what is the most challenging issue you faced and how it was resolved?
Well, I think if I start, I mean, professor has given a very, very tricky question. If I got to answer, I got to take another 1 hour because every little thing was challenging. So government, nothing goes easy. So challenges starts from make the doctors to understand they got to key in. That
Yeah. Hello. Hello. Is okay. Okay.
part entries will not be done. Then another challenge is a patient is given with a unique ID. He will come one day with that ID. Second day he will not carry a ID and he will register as a new patient. In other words, a single man will have 3 unique IDs. So that we have curbed it by using a overall unique identification. So a lot of such improvements happened and it will consistently happened over a time. Maybe I can give you a list of things happened and demonstrate when I meet all of you special session.
I think I have no other question at the moment.
Thank you.
Anybody else who want to know anything else, please let us know before we. Just a second, just hold the line.
Professor, was this presentation is the really, I mean, good? I mean, was it really run through well on the screen?
Yes, yes, it was really useful, and I have seen it, and I'm sure attendees would have done it well.
Yeah.
I am at the outset. I really want to thank.
Your audio is not coming.
Okay.
Yeah.
Just a
Thank
second.
you.
Hello.
Yeah.
Yeah, can you hear me now?
Yeah, I could hear you now. Yeah, please.
Okay. I said, Professor Armugam, thank you very much for your valuable time, and I'm sure the all attendees must have been benefited. And if they are thinking to do something like this is one is the pilot which is available to you to replicate. In case of any doubt for further, you can always contact any one of us on email. We will put you through to the Professor Armungam for the benefit of the society and the people. I think what it really is required to be done, those who are, this will be recorded, put it in the YouTube. You can again see. All those who could not attend or could not understand, they can also have a look at it, because this is the useful thing which you may like to understand. The all the questions, barring there was some duplication of the questions which I have avoided, but all the questions, luckily we had a time, because professor had managed it time very well, and that was what required a discussion, and doubts should be clarified to the people. To sum up, I am thankful to the professor and there is one last question has just landed, and I think I have got a minute, so I don't want to discourage the person, so I'll just read it out. Do you imagine data analysis and entry can ever be part of curriculum of a doctor's education? Myself being a doctor, I have never been trained with the importance of data entry.
I will answer this question. This is very important. As I always say, doctors must learn mathematics. They have to learn mathematics, and especially they must know analytics, because unfortunately doctors work on hypothesis. They should be more logical, and they should understand how easily they can get to a problem. I'm telling you a simple term, which was written by this, the Tesla. He wrote a epi term for Mr. The Edison. He mentioned it. Edison doesn't know mathematics, so he has to do 1,000 steps to solve a simple problem. What he would have done in one step, he would have taken 1,000 steps. That is one thing I always say. Doctors must learn mathematics. Mathematics must be made compulsory to medical doctors, and they must have analytics, because if they have these two, they will be doing their things very well.
Thank you very much. And
Thank you.
I will, in the end, will failing my duty if I don't thank not only attendees, but people on my side, my technical team, Alok, the management team, Clarion, and other people who made it success, and also the Cisco platform which we have taken it. Thank you very much, Professor, once again, and be in touch. Thank you.